Awesome. Cool. So we're recording. At any point in time you guys need to stop and edit something out, we'll stop, we'll pause, we can reset, and our editors will smooth it all so it sounds perfect. So I will get us started. I'll just start the show, and then Josh and Bill, you guys can introduce yourselves, and they'll just kind of flow right into first care provider, kind of the notes you guys sent, things like that.
Sounds good.
All right, good. So, hey guys, welcome to another episode of the Civilian Medical Podcast. My name is Dietrich, Skinny Medic on YouTube. Unfortunately, my partner Sean, who normally is on this podcast, is not able to make this episode. We're on episode 20 today, and we have some really cool guys who have a cool it's not a product, but it's a classroom thing that we're going to talk about. First care provider. I have Josh and Bill with me, so you guys can introduce yourselves to everybody, please.
Sure. I'll go first because Bill's pointing at me on camera. And, so my name's Josh Bobko. I'm an ER doc, and helped start First Care Provider with Bill probably 5-6 years ago, and really have sort of tried to create something a little bit different from what's currently available or what has been available. I guess for my background, I went to the Air Force Academy. Then I was active duty for a while, but it was all peacetime, so I didn't do anything cool. Be the first to admit that I got out and went to medical school separate from the military. But I will give just a quick background that my first assignment, I was at Seymour Johnson Air Force Base, and we got destroyed by a pretty big hurricane called Fran that essentially flooded half the state for about 3 months. So I got to spend part of my life living in an evacuation shelter while running it at the same time and working on sort of the community response to it. So, when I went into medicine, I kind of thought I wanted to do disaster medicine from the start. And then I started, I finished ER, went and I finished med school, went and did emergency medicine, trained up at George Washington, and started working with Reed Smith quite a bit, doing a lot of things there with him in Arlington and all the innovative things that they were doing back in the early 2000s. And then when I left there, I came out here to California and realized that I liked doing sort of small team stuff, and I like teaching, and I didn't want to be the new guy in my group. So I did a EMS fellowship out at Loma Linda, and through that was able to sort of start working in the law enforcement space with a faculty member that was actually an FBI agent out here. And he and I hooked up because we had been doing some similar kind of training. I was flying with the Sheriff's Air Rescue in San Bernardino out here, just doing, medical stuff, and then moved to Orange County like everybody else, because this is where my family is, and started First Care Provider. And about the same time Bill was getting out of the Navy, so it'll make a lot more sense once he tells you what he's doing, and then we'll tell you what we're doing together.
Awesome.
So that would be your cue, Bill.
Man,
listeners want to hear from you.
I know. Yeah, sorry, I was unmuting. I just didn't want you to hear the madness of my house in the background. My name is Bill Harris. I am, as Josh mentioned, I'm a retired military medic. I spent just under 21 years of active duty in the Navy as a hospital corpsman. For people who don't know what that is, it's essentially a medic, but we're a little different. I was an independent duty corpsman. I got to spend a good chunk of the first part of my career as a Greenside medic with the Marine Corps. Hoorah. I did a little bit of regular Navy. It wasn't my cup of tea. And I was fortunate enough to have had an opportunity to spend the last probably 40% of my career at Naval Special Warfare Development Group as a support medic. And that was right around the time I did a couple of Iraq and Afghanistan tours with the Marine Corps. And then the last half of my career, multiple deployments as a support medic at Dev Group. And really sort of honed my craft. Retired in 2011. And I have been teaching sort of ever since, a lot of TCCC, which then became TECC. Spent a lot of time training three-letter agencies and high-level SWAT agencies and first responders all over the globe. I started a website and a blog along with some good friends called Trauma Monkeys. And a little bit of bleed over. I've been following what you do, Skinny Medic, for a long time, and I love the work that you do. And just as Josh alluded to, it became very apparent to us early on that we would probably spend a good part of the future of our careers training first responders all over the planet. And we love that. We appreciate what they do for a living. But it became obvious to us that we come to your city, anybody comes to the city, and we train the first responders and we make them the best in the world. They're still 7 minutes away, and we're never really going to see a big change in the numbers. And in order to do that, we needed to spread the message more to the civilian public. And we need those folks that are there when an incident happens to be able to react. And nobody was truly serving that audience. And that's what compelled us to start the First Care Provider nonprofit organization.
Yeah, I know we've talked a good bit about it on the phone and stuff. And I think what you guys are doing with First Care Provider is awesome. I mean, Josh and I had lunch back at the NRA show. And, I think what you guys are doing is, because you're right. You can train and have the best medics, but they're still 7, 8, 9 minutes away. And for the things that you are teaching, the things that we're teaching together, it's gonna what ultimately saves lives.
Yeah, well, and that was it. Just became more and more obvious. Again, Bill was out here for a little bit working with doing some contracting, and I work with a bunch of teams out here, and we're constantly training these people. And it just, I don't want to say it dawned on us one day, but we just felt like, we've done this and we're only looking at half of the problem, right? We keep saying there's a bad event and we're working on the response, and we got to kind of work on the right there. So First Care was really born out of how do we take what we already know and make it into a package that is understandable and can be used by, our wife and our kids at home. Because we test, before we go and test, we'll show them, our kids and our wives see all the new equipment, everything that gets sent to us, everything that we're trialing. But we're like, how do we put this into some context where they kind of know what to do with all this stuff and what to do on their own? And that's where, that's kind of where we started. And it was, fortunate as far as timing goes. It was about the same. It was, soon after then that, the whole Stop the Bleed initiative started, which really sort of catapulted us into, the space where people knew what we were doing, other than just the friends that asked us to come do training and talk to their teams.
Yeah, the thing I would add to that, I think, Josh, is there were two things I think that became pretty clear to us early on. Is number one, we didn't just want to start a training company. As much as we love teaching and training, and it's obvious when we watch your videos, Skinny, you're the same way. What you realize early on is that's not a scalable thing, and you can never get out in front of enough folks.
That's true.
So we wanted to take, to widen the aperture and realize how do we get this information out to far more people than we can ever be in front of. And the other thing that was happening, we're certainly not the first people on the planet to have thought to come home and share the TCCC message. I'm sure many people were doing that. We were seeing that. The problem with that was there was a lack of standardization. And you have to kind of know who your audience is. And we say that a lot when we do instructor trainer classes. And what we were seeing is, guys and gals, to their credit, were trying to spread the message and trying to share this vital information, but they probably were presenting it in a way that it was presented to them. And frankly, you can't teach a group of Boy Scouts or Brownies or school nurses the same way you teach a SEAL team, or the same way you teach a grunt unit. And so we saw early on that everybody, to take a page from C textbook, everybody was trying to put a square peg in a round hole. And we kind of wanted to standardize some of that, and we wanted to simplify the message. Because the other thing that I think, if you look at TCCC, we teach an enormous amount of information. And in any course you go to, that's the case, right? You learn a little bit, and then you have to OJT the heck out of it. And in the military, we have the benefit of living with each other and deploying with each other and training with each other. And if you see a group for a day or 2 days or 3 hours, trying to jam an enormous amount of information into them and then send them away and thinking that they're going to be able to practically apply that without continuing to hone their craft is extremely unrealistic. So we really wanted to simplify it and figure out, what can people do? They can make a difference, and what are the tools we can give them in a short period of time to enable them to do so, to really change the outcomes of the preventable
I
traumatic
agree.
deaths.
It seems like you guys are, because everyone has a different teaching style, and maybe they were taught something different. Maybe even in EMS now, you still hear things that are wrong, or people not teaching updated stuff. So to be able to bring a program together and be able to say, you know what, we're going to present a unified message, the same message, whether I'm teaching it, you're teaching it, whoever's teaching it is delivering the same consistent message is important.
Yeah. And it's interesting because I've been part of the CTEC committee, and props to, Reed and Nelson and Dave Calloway and Josh Shapiro and all those guys that really started focusing on making this accessible for first responder agencies. And I've been able to be part of it, and I think, contributed quite a bit. But one of the things that Bill and I were sort of bringing to the attention of the committee was, look, when this whole thing, when things started, when the public started kind of demanding some sort of response, and really that came after Sandy Hook. I mean, that's the Sentinel event. You go and you shoot a bunch of kids. Now you got people's attention, and the White House decides we have to do something, right? And when that's going on, and people want something, we went to the committee very early on and said, hey, let's all get on the same page. Let's develop some data. Let's kind of do the same thing. And unfortunately, we weren't really able to successfully get everybody to kind of bite off on that. And I understand, because a lot of agencies, there's a lot of chiefs and administrators and mayors, they have their guys, they want their own plan, and that's fine. But I think what Bill and I kind of keyed on was, we have a bunch of friends all over the country that are doing the same thing. And as you said, there's a little bit of variance between how we're all doing it, but the principles are the same. So we wanted to build a program that was built on the principles, because we're 100% convinced that you can't just teach people how to do something. You have to teach them how to think about something. And once they know how to think about something, now they're going to remember how to do those things more successfully, particularly under stress, because that's exactly how we do with, our high level teams that we work with every day. You have to know how to approach problems based on, where the door is, where the entrance is, where your partners are, and there wasn't really a mechanism to do that other than just telling the public, hey, do this, do that. And that's where Bill and I were like, we can design a better mousetrap where people will be able to, in a very short order, look at a situation, apply some basic principles, and then, sort of the skills will follow. And I think that's what's really kind of made us as successful as we've been able to be. So it's a never ending mission. I mean, we've been evolving for 6 years.
Right. And the class, will change next year, 2 years. The program should definitely evolve and change, because you're going to learn things and change. Like, all right, this worked, this didn't work. New products come out, maybe things like that to kind of change what you're teaching.
Well, I think one of the other things is that we just, we didn't know what we were trying to do. We knew, we kind of had the sense of what we were trying to do, but we didn't know how to accomplish that mission. And initially, I think people kind of thought of first care provider as a course, and then we said, well, first care provider is not really a course, because Bill and I would travel around and we would train high level medics and nurses and, and docs to do our program. And while we were training, we would tell them, okay, you're teaching your public tomorrow. And they'd say, well, can you do the morning? We'll do the afternoon. We're still not ready. And we realized it's not the course, right? It's how do you prepare people to receive this information? How do you get them actively involved and get those teaching points across, not the content, but the actual education. And that's a totally different thing. And then since then we've kind of evolved into, there's an entire world out there that's asking the same question. And so, now we've really evolved into becoming sort of a social activation community where, if you're teaching Stop the Bleed, you can't call up the American College of Surgeons and talk to anybody about their Stop the Bleed course, or you can, but there's a lot of people that just kind of get the slides and then they're off on their own doing their own thing. And we've realized that there's a whole community, and this is where our communities overlap, where lots of people have the same questions. If we can get them all talking to each other, we can get some really great intel from across the world, and now we can raise the conversation. We can work out those finer points. We can see what works and doesn't work in different countries and different languages and different, cultures. And really that's what First Care has become.
So if someone was looking for a First Care Provider course, I know we've got some other things we're going to talk about in a minute, but like, it's what I would think, and you can correct me if I'm wrong, it's basically Stop the Bleed on steroids. Like Stop the Bleed is a good class, but there's gaps in it. And you guys kind of took that and expanded that program, correct?
Well, I mean, it's a great question. And it's, we didn't really expand it because your description of it is great. It is sort of Stop the Bleed on steroids. We were doing it before there ever was a Stop the Bleed. And our take has always sort of been, if we're going to get people together in a room and we're going to teach them, why would we limit what we teach them to just one of the preventable causes of death? It doesn't take that much longer to teach somebody how to roll somebody in the recovery position. You don't have to go, to med school to learn how to apply a sticker to for a chest seal. You don't have to, you don't have to be a paramedic to apply an emergency blanket. So in the beginning, we were a little frustrated with Stop the Bleed. And we thought, much like CTEC's sort of view of it, is that Stop the Bleed was a very myopic thing. Didn't seem like it was well thought out. It was focus grouped, and it's a great catchy slogan. But frankly, it's doing people a little bit of disservice. And so we kind of fought against it. More like, hey, we want it to be the anti-Stop the Bleed. And then we kind of pivoted and realized, well, that doesn't make sense, right? The government's promoting this, and it is a good campaign. How do we get involved and make it better? So now we have two programs, and we wanted to serve the people that are doing Stop the Bleed, because you can come up with a great program, and we believe our First Care Provider program is way more robust, and we believe it's what everybody should do. But frankly, there's time and there's commitment and there's money involved, and trying to get organizations to come up off of those things or to make room for those things from a budget standpoint or from a time standpoint is difficult. So what our approach has been, number one, is from the nonprofit. And Josh kind of summed up, hey, what are we? More than anything, now we're a movement. We're a movement of folks that are far bigger than just a handful of us vets and first responders that started this, that are all collectively moving to try to educate the world and make their communities and the world a safer place by giving the skills and the tools to the people that need them the most. And so, what we figured out is, okay, if you're going to do a Stop the Bleed course, be the best you can be at it, maximize the amount of time that you have with these folks, have them leave better than when they got there. And the people that get it and the people that leave wanting more, there's another step for them. And that's to become a certified First Care Provider. And if you do your job the way you're supposed to, it's not about the instructor, it's about the message. And you deliver the message correctly, the light bulbs go off. And I know teacher, because you're an instructor, and you see it where people don't get it, and all of a sudden you see that look on their face like, oh wow. I certainly need to know what to do, and I'm not as prepared as I thought I was with my wife and kids.
Yeah. The other thing I wanted I was just going to say, just to tag on to that, I think it comes down to expectations. And I had this conversation several years ago with some, important people in the Stop the Bleed community, and what was being put out to the public and what we were seeing with our actual contact time with the communities we were working with were not the same thing. There was this idea from the top down. And well, first off, let me backtrack for a second. Again, Stop the Bleed is an initiative. And what Stop the Bleed is, for those people that maybe don't know, and I know you've got a great audience, Skinny, because, we're part of it. But it's all it is the government, for too long as first responder agencies and communities, we've been afraid to tell the public the truth, that we can't be everywhere. We don't have enough people. There's not enough money. And what Stop the Bleed is the government telling those communities, look, it's okay to self-identify and tell your public, we need you to be part of this. Because for years we were afraid to do that. And so it's an initiative that I think has been, strategically manipulated to make people think that it's an actual course taught by one agency, and that's not the case. But what we were seeing was the people that we were teaching, and the people that would go to the courses being put on by the agencies that we were teaching, like to a person, they would stick around and they wanted more. They would never leave at the end of class. Not that you want them to, but sort of the government perspective was, the public can only handle one very basic skill set. And I just don't believe that's true. Bill doesn't believe that's true, because we've seen it. And when you are able to engage your public and that light bulb goes on, and they suddenly understand why it is that they are doing what you're telling them to do, and they can personalize that to kind of picture themselves in different situations or with their loved ones. Now, like, all that other stuff goes out the window. They will focus 100% on what you were telling them. And when they're done with the class, they want more. And, it just kept growing like that. And it was just inconsistent with sort of the messaging that was coming from above, was not consistent with our experience, which is exactly why we became a nonprofit. We were frustrated ourselves, because we were trying to go through agencies and governments and trying to say, hey, you should be doing this, you should be doing that. And you run into all these snags until you create a mechanism where you can go directly to the public themselves, and you don't scare them, and then they really engage. And next thing you've got waiting lists, or 300 people on a Saturday afternoon to come to the class with their kids. Like, that to us is what Stop the Bleed is supposed to be, and that's what we're trying to accomplish.
Yeah, I love teaching citizens, the regular average person. I teach now EMTs. I teach paramedics. I teach at the medical school. The medical students are awesome, but a lot of times I'm teaching a firefighter who doesn't want to be in an EMT class. They get in the fire service because they wanted to fight fires, not because they wanted to run medical calls.
Right.
So they're kind of just there because they have to be. So when we started doing some Stop the Bleed classes and some other classes, these average people, civilians, started coming, and like they're just wanted to grab a hold of all this information. I mean, they've traveled. We have several people who've traveled a long way to come to our class. So they've paid gas money, hotel money, travel time, money, and now they're wanting to get as much information out of this class as possible. So they're like sponges. Like, you tell them, like, all right, this is what you're going to do this for, and they're going to get in the floor. They're going to put tourniquets on, and they want as much information as they can grab a hold of during that day. And I agree that the Stop the Bleed is a good program. It's a good initiative, but there's more. And to say that an average person, a mom, can't put a chest seal on is dumb. Like, I think a mom can very easily open up a Hyphen, Halo, whatever chest seal, open it up, recognize that there's a hole in the chest, and put a packaging over it.
Yeah, and I guess at this point we should probably pause for a second too, and congratulate Paul Brooks up at DHS that was the single engine driving force behind the entire Stop the Bleed movement that's now taken over the world. That guy's a hero in everybody's book. And then I also want to say, for the guys that organized the Stop the Bleed Day 2 years ago, and then Stop the Bleed Month last year, Andy Fisher and John Lacroix, I think what was critical there was Stop the Bleed kind of came out with a goal, but didn't know how to achieve its mission. And those guys really stepped up and organized the effort and created, their state POCs and really gave some shape to this nebulous idea that, the government was trying to get across. And I think without that legwork, it wouldn't be as ubiquitous as it kind of is now. And of course, there's still work to be done, but, kudos to those to those gentlemen that have really, really changed the way the world is approaching this problem. And again, we see it every day because, we've got people in, I think at last count, we're up to like 65 countries now, with first care, and they're doing first care, and they're asking about Stop the Bleed. And that's exactly because of the work that those gentlemen have done. So, but we're all facing the same thing. We're all in front of our public, and we're all seeing what the public is telling us. And it's just, we just see how eager they are. Like, they want this information, and they want to do it right, and they want to practice, and they are willing to spend their own time and their own money to do it. And, we just got to keep pushing.
I agree 100%. The Stop the Bleed Day month, that's been a good initiative. And like I said, we were talking about a minute ago, but the fact that, it's an hour and a half class, maybe, there's been some faster ones out there too, maybe a little 2-hour class, but they stop and like, all right, I want more. Like, what's the next step? Yeah. I don't want to maybe go to EMT school. Maybe I don't have time for that. Maybe they don't want to take a first responder course, but they want more. Like, what's the next step? So I think for our listeners who have had a Stop the Bleed class, they've had, some tourniquet training, I think a first care provider course is the answer to that. The next step, to find one of these classes and take it. Yeah.
Well, and again, we're building that community, and what you had said earlier about teaching and the public, I actually just want to throw this in because I remember, this is the 25th anniversary from me being at the academy as a SMAC and getting my head shaved, and the class that's there now all have gold hats like I did. But one of the things that you had to memorize is a bunch of historical quotes. And there's a General Patton quote that says that you never tell people how to do something, tell them what to do, and they'll surprise you with their ingenuity. And that's kind of our approach, right? Let's teach them how to think, and then they will figure this out and they will make good decisions. But you got to give them that framework. And I think, maybe I'm going to let Bill jump in on this part, because we've actually started to offer care for law enforcement, because the reality is there's some, right now, like, why isn't the whole world using the same acronym? Why do you teach your patrol officers march, and then you turn around and teach your public care, when the patrol officers, they can't start IVs, they don't do resuscitation. If they're waiting to the sixth step of their algorithm to check for a pulse, then something's wrong. And there's plenty of data that says that, under stress, people don't remember 5 things. They remember, they don't remember 7 things. They remember 5 plus or minus 2, right? Mm-hmm. So we've kind of evolved to try to get everybody on the same page. And Bill's been doing a ton of that, with his agency and going around and sort of trying to get everybody unified.
Yeah, I think you're right, Josh. I think it works from the bottom up, like the STB folks or the intro folks that are looking for more. First care provider is a perfect fit. And then the other thing we realized is the patrol officers, those folks that you only get a small window of time with, these people are doing everything they can to get themselves in a TECC course somewhere or whatever. And then, or even some of them are still trying to get in TCCC classes. And again, that's not really the intended class for that audience. And frankly, it's such a short window of time that they're drinking from the fire hose, and there's just an unrealistic expectation of them to go back and start doing these things. And you're copying a lot of it. Again, it sort of replicates the military model, and the military model, although not perfect, there's some great things we can pull out of it. But there's clearly some differences, right? Not written, right? Josh is the one that wrote the pediatric guidelines for TECC. So if that military model, relies on the medics and it relies on constant training, hip pocket lecture, standing up while we're, that hurry up and wait military mantra, we sit around all the time. Okay, let's go through tourniquet drills. And, if you got a standard patrol officer and he gets, 1 4-hour session or 1 2-day block a year to train, it's not the same thing. And so we want to give them as much accurate information that's simplified and digestible. And we think care and first care provider for them makes way more sense. We go through the algorithm. They learn to fix the preventable causes of traumatic death, and they learn how to do it well. And then they get lots and lots of reps, which we all know we need more of. Nobody's ever been to a class and said, hey, we need less hands-on, more PowerPoint. Like, that's not what happens.
No
we
one
know
ever
how
says
people learn.
that. Yeah. So
and frankly, we do the same thing. It's our biggest struggle. Like, we want to share C stories. We want to tell people why it matters to us. And the challenge is limiting that and not stripping the students of the opportunity to get their hands on these things, and frankly, to start making mistakes. Because the more mistakes they make in front of a certified trainer, the less likely they are to make a mistake if they have to do this thing on game day.
Yeah,
I do want to talk about the algorithm thing. Like, that is one of the things, like, I wish we could all just get on board with the same algorithm, because you've got like March, and then I took a alert class not too long ago, and like they're using Bath, I believe, correct?
Yeah.
And I was like, why can't, like, we have so many different algorithms that are acronyms that are doing the exact same thing, basically. I mean, like, can we not kind of like unify that one?
It was one of the needs that sits in.
He's using different ones. I think some of the Army still uses XABC. Some of them use something else.
Yeah. So I'll tell you, as one of the guys that sits in some of these meetings, you got to understand that everybody wants to be the expert, right? And I'm not saying that we're not the same. We would love for everybody to use our thing, but what bugs me is that I see people, saying things in like Facebook communities as if they're gospel, right? They'll say, oh, well, they'll say, I need TCCC training for my cops. And somebody will say, well, really, you need TECC training for your cops because you're not in combat. And then they'll say, well, it's the same thing. I just mean TCCC for law enforcement. And then we do TECC for everybody else. And like, that just shows a fundamental misunderstanding. And, again, just the public like the misinformation that's getting propagated, because there's a lot of third generation PowerPoint experts running around. But, again, so going back to the algorithms that you're talking about, we didn't, there's Scabby and XABC and Bath and all of these other things. And that's fine. If you have something and it works, great. But what I can tell you with 100% certainty and show you the statistics to back it up is that the public understands care, right? And if you go to talk to them about, the Hartford Consensus came up with threat. Let me tell you something. When the public is under stress, they're not going to stop and work through an algorithm that's 6 letters long is not easy to remember. But if you tell them somebody, your kid is hurt, care for them, now they can kind of do that. It's a lot simpler. And so it wasn't designed because everything else was bad. We just really subscribed to keeping it simple. And quite frankly, it's the Occam's razor, right? The easiest answer is sometimes the right one. And we're very, very keen on only teaching people 2 things. If you're a civilian and you're in some sort of threat, then we want you to race to safety. And if there's somebody injured, we want you to care for the injured. And those are the only 2 things. And you can teach the entire half-day class off of one, business card. And we've had people do that, where other courses, we had one of our friends, Abbott Carter is I think is he a sheriff, Bill, up in Ohio. And he had gone because his agency was doing some stop-the-bleed training.
Right, and EMT as well, I believe.
And yeah, well, he had gone to go help do some stop-the-bleed training for the department for his shift, and I guess for the explorers. And the instructor was going to do another stop-the-bleed course that everybody's aware of, but they couldn't get the PowerPoint to work, and they didn't know what they were going to do, and so they were going to cancel the class. And it's like, wait a second, like how in the world are we at the point that we can't teach stop the bleed without a PowerPoint? That's fundamentally flawed. And so he jumped in and he had his care card, and he taught the entire course off of the business card with a whiteboard. And, suddenly now the sheriff is really excited about the potential to do more of this training. And realistically, we've got those stories coming from all over, because it's just understanding the concepts.
And then will you let us know what RACE and CARE stands for?
Bill, yeah, Bill, you got the camera there. You want to go through it with your card?
Yeah, I don't think he's going to show video, but yeah, and it's funny because when we first made these and we were giving them out and listing them, we were like really intentional about saying, make sure you get yourself some care cards and not race cards. That's not something we wanted to provide the public. But yeah, as Josh sort of alluded to, in an emergency, we want people to race to safety, right? And we talk a lot about, and I know, in the EMS world, is the scene safe, right? And that's just something that gets regurgitated, but we do our students a disservice because it doesn't mean anything, right? They just check a box and say that. And so
everybody does
we took that and said,
dance.
Yeah, totally.
And it means nothing, right? It's you fail if you fail to do it. And what we're trying to say is, let's not replicate that just because it's what we've always done, right? The question should be, is it safe enough, right? Because if we're looking at active shooter, if we're looking at rescue task force, if we're looking at all these things with joint integration, well, we're getting away from them making sure it's 100% safe because that takes too long and people's lives are at stake. So it's never going to be safe. The world's not a safe place. Working on the side of the road is not safe. Going to a building that's on fire is not safe. So is it safe enough makes more sense. And then the next question, which they should be asking, everybody should be asking, is there something I can do to make it safer before I start applying a tourniquet, before I start doing whatever it is? So that race to safety algorithm for us is, RACE, and the first thing is react. We want people to just do something. And really, we want to call attention to the fact that it seems obvious that if you saw something, you'd want to help. But we know, having looked at study after study after study, that normalcy bias kicks in and that people don't have the ability to process these things. And we talk a lot about that 10-80-10 rule, right? 10% of the people rise to the occasion and make the scene better, make the situation better. 10% of the people make a situation worse, and 80% of the people do absolutely nothing. And we want to get the people in that 80% tile moved over to the upper 10%. And so we just want to make people aware of the fact that if you're thinking ahead of time about what could go wrong, if you formulate a plan, you can't go anywhere physically that you don't go in your mind first. So if you just think about where the exits are, be a little more situationally aware, put the phone away, all those common sense things, you're going to be much more likely to react if and when there's a threat or an emergency of any type. If you get some medical training, you're liable to react. If you get CPR qualified, you're liable to provide treatment. So the first part is react. The next thing is activating the 911 system, which I think people are aware of. But I always say, times have changed and the way we communicate has changed significantly. And I hold my iPhone up and I tell them, my kids don't know that this is a telephone. This is the way that they, get on Snapchat, or this is the way that they play Fortnite. And we see real world events happening and people are tweeting it out, or people are putting it out through social media. So, the 911 system itself, the government has mandated that it be updated and fixed because it's an outdated, antiquated system based on landline phones. And I always say, if you're on the 27th floor of Manhattan, they can maybe figure out what block you're on, but they're never going to find you. Yet, I wear an Apple Watch and I can press one button and I can have a pizza here in 20 minutes. Right? So we want to talk about the ways that people can activate that 911 system faster, right? What municipalities offer the ability to text 911? What things should you do if you're running and hiding and fighting or avoiding, denying, defending from an active shooter standpoint? You can still call and just, keep it connected without talking. So all these different things about activating the system. And, frankly, the first responders that we have in this country are the best on the planet. They're training like crazy and they're doing an amazing job to get to you, but they can't start doing that if we don't get the word to them. And so that's the activate piece. And the other piece of activate is getting those people that we talked about that are sort of frozen or stuck in what we call that deliberation arc, is activating them. A lot of times in an emergency, people want to help, but they're waiting for somebody to tell them what to do. They're looking around for who's in charge here, who's gonna tell me what to do. And so we want folks that can size up a scene or that can understand what's happening in real time. We want them to activate people, give people a job, point them in the direction. You call 911. You come over here and hold pressure on this wound. You stand over here and look for the ambulance when it comes, whatever it is. We want people to take charge and sort of activate those that need to be mobilized. And then the C portion of RACE is the care portion, which is the whole other algorithm, right? How you provide good, adequate medical care for a trauma victim, right? Controlling the bleeding, managing the airway, checking the respirations, exposing when it makes sense and sealing up holes, and then preventing exposure or minimizing exposure, right? keeping the hypothermia thing at bay because it kills patients. And then the last part of our race safety is evacuation. And when we have time, we try to teach people how to move people and how to drag people and how to lift people. And more than anything, that conversation is really about having realistic expectations, because this is one of my favorite subjects to teach, because forever we glazed over this. We just assume, hey, medics and firefighters and cops, they'll know how to move people. They do it every day. And the problem is they do it every day using the tools that they have at their disposal every day. And typically it's onesie twosie. And when you show up to a San Bernardino type event or a Vegas event, that all goes out the window. So getting people to think about using wheelbarrows and getting people to use about bell cards and teaching people good, effective ways to physically move somebody. And I think the misconception, I know from the military, one of the things I learned is we all had this misconception that I don't think I could feasibly carry a 275-pound man with kit and body armor and weapon up and down 5 flights of stairs. But if it was a real emergency, I'd find a way to do it because adrenaline would kick in. And I think a lot of people are out thinking that. And so what we want to try to do in some of these classes is what you do, we say train like you fight. If you can't do it today, you're certainly not going to be able to do it on game day. So what are the things we can do? What are some tools and some tips we've learned? How can you use what you have around you, what's at your disposal to move people? And evacuating people sometimes is moving them closer to where help is going to be. And sometimes it's moving help closer, or both, right? Finding a way to get those trained first responders to the people and the people to them as quickly as possible. And we touched a little bit on acronyms. And when I teach, I always say, whether you're using March or whether you're using CARE or whatever you're using, there should always be a G at the end for gas pedal. Because the reality is all of this stuff is point of injury wounding. It's a point of injury treatment, and it's great. But if it's not followed with prompt, as fast as possible delivery to a higher level of care, then it's all for naught. And we can't lose sight of that. And that's an important message. And that for us is that race algorithm. And that's kind of the message that we want people to take away.
So Josh, you talk about you have a card we hand out, and you guys also have an app that people can download.
Yeah, absolutely. We've got so there's one of the things that we found, again, as we were, building this network, is a lot of folks would either come in because their agency got a grant and they bought a bunch of IFACs, and then they sort of backpedaled and tried to figure out what to do about training with them. And that happens in police department. We still see things all over, Facebook groups and such saying, my department doesn't have IFACs. How do we get them for grant money? And, we're still fighting that very basic fight. But what would happen is, the training would be kind of hodgepodge last minute, or people would get some training and then they'd walk out the door and there'd be no equipment because they're trying to get a grant or they're gonna buy something. And so we, even though we weren't at the position where we could just give away equipment, what we thought of was, hey, we got to have a way to have some sustainability for our process and a way for people to stay current. So we made the app, and it's available on the iOS, App Store and the Google Play Store, and it's free, and we don't make any money off of it. But what it is essentially, I like to teach a class.
Josh, if they go to firstcareprovider.org/app, there's links right there for where you can get it.
You want to say that again?
Yeah, if they go to firstcareprovider.org/app, APP, all of the links are there for directly download. Like you said, they can go to iTunes or their app store and get it. But
yeah, and so as we had said, our course is really a way of approaching a problem, and you can teach it from an index card, and you can walk into the room and tell everybody to download the app, walk them through the index card. They can follow along on the app when they leave the class or the seminar or the workshop that you're putting on. Now they can go back and look at it. It's got way more information than is in the Stop the Bleed class. So it was just a way to create a little bit of sustainability, because too often, we're like, so much of first responder training is just, we're going to immerse you in this training for one day. And I'll tell you, in medicine, there's tons of studies that say you can spend all day learning a surgical procedure, and that's fine. But the people that do it a little bit every day are better. And it's the same thing when you're doing weapons training. It's the same thing when you're doing any training. And so why we do med training differently and expect we're just going to a quick hit and then get out and then everybody's going to remember everything perfectly. That's a fallacy. And so we wanted to combat that by making it available to everyone. So we made the app really as a learning tool.
Yeah, and there's plenty of data that shows that, people take CPR classes and then they get retested, 3 months, 6 months later, and they're not proficient doing CPR anymore. So that same thing would go, same thing we're talking about, tourniquets, pressure bandages, wound packing, chest seals. If they're not staying proficient, they will lose those skills over time quickly.
100%.
And on that note, I think that's the biggest challenge we all face collectively as instructors, because I always feel like you're standing up there and you need to give two messages to the public. One is that they absolutely can make a difference and they can save lives, but then you need to follow that with, hey, it's not going to be as easy in the real world, and you're going to need to practice this. And that can be really challenging because you're kind of talking out of both sides of your mouth. And then the way that we say to do that is empower them, but let them do it, and then start stepping it up, right? Start ratcheting up a little bit of the stress, right? Start running a clock for 30 seconds, start dimming the lights, start having them do it on somebody who's not happy about the fact that they're putting it on. And then they'll start seeing it's not quite as easy as putting it on a tourniquet or a bandage, like you said, on a cooperative person. So, but yeah, I think that's the struggle is, right? You're trying to deliver two messages at the same time.
Yeah, absolutely. I mean, everyone we talked about before, PowerPoints, nobody wants to be PowerPoint by death on a Saturday morning. So getting the students up, letting them practice, and then get them comfortable with it. Maybe they play with different tourniquets on the market and say, all right, this is the one, the CAT soft T, maybe the TX2, TX3, or whatever, CAT soft T. They're playing with those, and then all right, let's do the 30-second time. Stage it, put it in your pocket, boom, let's go. And then, like you were saying, like maybe turn the lights out. They're already, you don't have to overstress them because they're already probably a little stressed out anyway, because they're nervous. It's their first time they've done something like this, that they're out of their comfort zone. There's no need to, freak them out totally, but you want to increase the stress level a little bit. I don't play really loud music for my civilians,
No.
but like, all right, cool, let's do it. Let's get a little excited. And if I get a young kid in there, 16 years old, like I will make him do some push-ups just to kind of like, all right, let's get your heart rate up. Let's play with you a little bit. But for the average person, I've done tourniquet training for like 80-year-olds. Like this 80-year-old grandma want to know how to put a tourniquet on. That's awesome. Like I will walk her through it so she knows how to do it. So absolutely, I love it. I think the hands-on is where it's at, and that builds up muscle memory for these people.
Hey, Dietrich, let me just jump in because, one of the easiest ways to ramp up pressure that we found is just tell people you're going to film them and then show them the video. And you literally pointing a phone at them, even if you don't turn it on, will freak them out. And we do that in our Instructor Development Academy,
It's a great idea.
To make people, just make them conscious of what they are actually doing and saying. And they're their own hardest critic. And once they can get through that, now you really engage them and empower them to be successful.
Yeah, that's a great idea, because we would run calls like at the jail, and I was a field training officer for a large service, and I'd be like, all right, Proby, we are getting ready to go in the jail. You're going to be recorded. So watch what you say, watch what you do. Like if there's a camera around, your game steps up a little bit.
100%.
So you want to,
yeah, I think it's that they have that effect with the camera, because the flip side is when a lot of folks first come in, they don't understand what the class is, right? They want a box to put it in that they're familiar with. So they say, oh, it's a CPR class, or oh, it's a first aid class. And then, you realize it's not that. And then when we say the focus of this obviously is going to be hemorrhage control, I think a lot of the adults that are out there think, I've learned that already. I was a Boy Scout. I was this. I was in the military 35 years ago. So everybody thinks they've got the hemorrhage control part down. And then all of a sudden you're presenting concepts that are so different. And the ones that were really loud and proud in the beginning are suddenly like, oh, maybe I need a volunteer to go first. And they're like, hands are down. They're letting the 80-year-old go first playing a tourniquet before they. So it's interesting to see that. That Josh, you touched on that Instructor Development Academy, and that was something we started mainly because we just wanted to share the information, and collectively, like if you're new at this, and we get so many folks that we get emails every day that I got voluntold that I need to start doing this, and where do I start? I downloaded the PowerPoint, whether they downloaded ours, which, you can get, or whether you got the American College of Surgeons. But now I've got a class on Monday. Where do I begin? Right. And so rather than have them fail at this or make mistakes, we said, let's create a community of folks that have been doing this for a long time, and folks that are at all different levels and different stages of the game where they can get together and share their ideas. And frankly, the course is great, but the real value is that private Facebook group, because the people in there are sharing their success stories, and you've got people that are one step or two steps ahead of you, which is a way different perspective than Josh and I, or you even, Dietrich, who now have been doing this from a very high level for a long period of time. So, you forget the stuff you didn't know in the beginning. And so it's great to see those folks be able to pop in that group and say, here's what I'm struggling with. How do I get past this? Here's what I need. And the other thing that we talk about in the Instructor Development Academy, but I don't think comes up, is if you feel compelled to do this, which frankly, you should, and it's great that you do, but there's a cost involved. Just to buy, 10, 20 training tourniquets costs a lot of money. Then you start factoring in all of the different devices that are out there, all of the training things that are out there. And we've been blessed to have worked with some great agencies and be able to get our hands on some of the most high fidelity mannequins and great bleeding devices. And the companies have been fabulous with us, the Focuses of the world and North American Rescues and such, ITTS, all of them. But expecting that somebody who just sets up shop and wants to start offering this to their women's protection group or to their business, there's a significant cost involved in that. So at their gun range, exactly. So we wanted to create a program where if you had questions in the beginning, you didn't make a mistake on purchasing something that maybe wasn't going to serve your audience the best. And so that's why we started the Instructor Academy, and to do the slide deck step by step and to explain the intent of each slide. And if anybody wants information on that, again, it's firstcareprovider.org/academy. And you can get all the info. You can reach out to us. We have a full 100% money back guarantee. And people will ask, and it's worth probably talking about now.
Sorry, I stepped on you. I was going to say, we haven't had anybody ask for any money back, and it works for any Stop the Bleed program. Honestly, it works for any program you're teaching. And not to toot our own horns, but I'll toot Bill's horn and say that, like, this comes after teaching a ton of different classes to a ton of different audience, literally all over the world. And there are some, just like there's some basic principles in being in a disaster, there's some basic principles in teaching a course that the people that are really good at teaching, you can tell that they're really good because it looks so easy, but it's because they have a process. And the people that think, oh, just give me we would get this all the time. Hey, Doc, can I borrow your slide deck? And I'm going to go teach. And that's not where the magic happens, right? The magic is in the mindset and the preparation and knowing, what stories you're going to tell and how you want to leave your audience wanting more. And I think too many people are just like, I just need I have 30 years experience as XYZ. Just give me a PowerPoint presentation and I'll go make it happen. And that's great. And you can feel great about yourself, but are you really effectively educating your audience is a totally different thing. So we built the Academy to try to help with that.
That's an awesome resource.
Yeah. And it's interesting the way you phrase it, Doc, because I think that was a lot of what we both saw in the beginning with TECC and TCCC is medics would stand up in front of a class of non-medics and then teach them to do things that they do as medics. And that doesn't work. Like, you're a medic, you have pain management. You're a medic, you carry 26 tourniquets and 97 compressed gauzes. And now you're teaching every civilian in the world or every non-medic to take the IFAC, which is an individual first aid kit, right? And ball up the rest of your gauze on top for pressure. And then I would tell the medic, hey man, that's 90% of the gauze that he owns doing nothing but putting pressure on top. What's going to happen when he cuts the other pant leg off and there's 27 more holes to plug? And the medic goes, oh, I didn't think of that, right? Because you can't teach non-medics to work the same way we work. They don't have the same scope of practice. They don't have the same skills. And they don't have the same equipment. So, you have to look at it from the end user's point of view, and the course and the curriculum and the way we teach has to be designed that way.
That's great. You can think about it too. A lot of times, we, if I go pull my SWAT vest out now, there's probably 4 packs of combat calls in there. And the average civilian is going to go, I can't afford that. I'm going to run compressed calls or whatever. So having them to say, it's a different mindset. I pulled a jet tourniquet out of my backpack the other day. I'm like, oh yeah, and I'm just carrying around a jet. I'm like, okay. but the average person is not going to be able to pull out a jet tourniquet out of the back of their truck going, all right, let's put this on.
Yeah,
absolutely.
Even if you scale back from that, just look at the tourniquets themselves, right? It's hard enough to get somebody to purchase a tourniquet, and then we're following it up with, oh, you need another one to train with, right? And it's a perishable skill, and you got to practice it a lot. So now they got to start off buying two, and they don't want to do that. Now, some of the tourniquets you don't have to do that. Some of them can be practiced with, but the more common tourniquets that are out there, you need to practice one too. And the agency's the same thing. Hey, you need to buy 100 of these to issue out, and you need to buy another 100 for training and rotate them. And, that's a hard sell.
Definitely. I agree. Just the fact that, it is difficult for people, they want to go buy a $500 Glock or $400 Glock or whatever. And like, all right, I'll do this. And now it's, I'll upgrade the sights, I'll upgrade the trigger. And they're like, all right, cool. We want you to come take a medical class. We want you to spend $100 on an IFAC. And they're like, I can't do that. But it does seem, though, that there is a movement, and it does seem like I noticed the NRA this year, like there's more and more people talking about medical. And so I do think it's a process that's growing. It's got to get the snowball going. People thinking about like if you carry a firearm, you should carry a medical kit, and you should know how to use it. If you're, a school teacher, you should absolutely know how to have your own medical kit in your desk probably, and know how to use it and be able to help save lives.
Yeah. And I think that's,
yeah.
I'm sorry, Bill. I was going to say, I think that's one of the things where, it's really all about mindset, right? And you had mentioned earlier, Skinny, that when people say, oh, they got to teach us stop the bleed. And we get this feedback too. Oh, I have to teach stop the bleed. And they'll say yes. And then they're told, well, you only have 45 minutes. Mm-hmm. We have to have the academic integrity to tell whatever administrator is putting that on you to say that is not a reasonable situation, right? Like I can teach you how to put on a tourniquet, and that's about it. And realistically, that isn't going to do anybody any good in a time of stress. And so what's our goal here? Is our goal to just say that we trained a bunch of people? Is our goal to just say we signed up a bunch of instructors because now, podiatrists and pharmacists and, all of these other people, allied health people, no offense, they do great things, but they don't know the first thing about pre-hospital care. And so, to give somebody either an unreasonable amount of time or to have zero sort of quality control with the instruction that's being put out, I think is a real disservice to the public. And, you have to question what is the goal of that. And so, we really wanted to create that, this Instructor Development Academy, because, the other thing that comes out is instructors saying, well, it's free. It's a free class. Can I charge for it? Or somebody trying to charge for it, and then somebody giving them a hard time and saying, well, why are you charging for it if it's free online? And the reality is that that's because it was presented as, here's the information, go out and teach, and anybody can do it. And the reality is not anybody can do it. Anybody can learn to do it, but you have to learn the skill to be able to teach it. And if you have the skills, then by all means, go and charge for it. But again, I think you kind of have to parse through some of the what's being fed to the public and really look at it as, what are we trying to accomplish here? And so again, the point of the Instructor Development Academy is, we've got tons of folks that have no experience that want to do this, let alone the people that are being assigned to do this. And, we wanted to have an attainable sort of accreditation process that they would be able to, and not accreditation, but basically be able to answer the question that they are going to be expecting from their public, because before that, there's no way to know that until you're actually standing in front of the public. And that's not a good place to kind of work out those problems.
I agree. I think you guys are doing, the goals are on point. What you're trying to accomplish with people is just get them motivated. And I think people are ultimately, if they're going to sign up to come take a half-day class, take out their Saturday morning, Saturday afternoon, they're already proven that they're motivated. So, trying to give them the right equipment. Now you're giving them the right knowledge. I think it's a great thing.
Yeah, the public is really good at.
Yeah, and
I'm sorry, Bill. I keep jumping in, but I'll jump out real quick. The public's really good at sniffing out BS, right? So when you stand in front of somebody to teach them, you've got about 30 seconds for them to decide whether they believe what you're saying or they're just going to tune out and be on Instagram the whole time. We were sort of putting people in that situation way too much, and we wanted to change it.
Yeah, I was just going to say I kind of agreed and wanted to echo your words, Cindy. I think the gun community is a very progressive community, and we found out early on when we wanted to start spreading the message. Folks like Krav Maga studios, self-defense places, firearms, those are people who are already very proactive, have a proactive versus reactive mindset, and those are people who are willing to invest time and money in improving themselves and are willing to accept that bad things can and do happen. So it's a lot easier to make inroads. And frankly, I think those folks have embraced it more, to their credit, and they're doing a good job. And the message slowly trickling out of the agencies in those spaces is, hey, carrying a gun and being trained to carry a firearm and not having medical equipment and training is negligent. And we've even gone so far as to want to add an additional weapons firearm safety rule. Right, we all know the basic firearm safety rules, right? Keep your fingers straight off the trigger. Don't point anything into you. We think there should be one saying, "Hey, I have a plan, and I have a medical plan in the event of an accident or emergency." Right? Just verbalizing that and saying that means you talked about it and you're thinking about it. You know what your plan is, and even if your plan is just to call 911, verifying you have cell service and thinking about where they're coming from. But we think that's something that should be articulated, and we think that there'll be value in that. So yes, those communities are probably where you're going to see far more effort, and they're leading the way. And it's the rest of the communities that are now following suit. So to their credit, it's finally taking hold. The other thing we're doing, we're doing a lot of stop the bleed stuff. And like I said, that wasn't the intention. We initially had a lot of reservations about embracing, and this podcast is a great example of it, of embracing the technology, because it's a human interaction thing and because these are hands-on skill sets. And we really struggled with how do we harness the power of videos and YouTube and the internet and webinars and Facebook to teach people something that has to be a hands-on skill set. And so that made it very difficult for us to scale, because what we didn't want to do was just turn around and say, everybody's an instructor. Here you go, you're an instructor, especially for the first care provider program. And if you want to certify first care providers, you had to have been specifically trained by a very, very small select group of cadre. So we knew that when you stood up there in front of people, you could understand the depth of what you were teaching beyond the level of just the slide. And so we finally now have sort of perfected, I wouldn't say perfected, but we've gotten a lot better at harnessing the value of the technology. And we use the Stop the Bleed platform as a way of doing that. We beta tested it, we've improved upon it, and we've had hundreds of graduates come through that like it, and we're now ready to take that next step with our first care provider instructor course. And so we're going to beta that only for the first 100 folks that are interested and give them an opportunity. And again, we're not looking for everybody on the planet to sign up for this. This is not for everyone. This is for the folks that want to do something different. This is for the folks that are looking to learn. This is for the folks that are looking to give back. This is for people that want to put forth an effort. If you're just looking to download a PowerPoint, there's a lot of agencies that'll do that. If you're just looking for checking the box, there's agencies that'll do that. That's not what we do. We are going to have you do teach backs. You're going to have to, demonstrate that you can speak proficiently about these things and answer questions and take an exam. So what we'll do is I'll put a coupon code, Skinny, for your listeners. If folks are interested, they can go to firstcareprovider.org/skinny. And I'll put up a page up on our website specifically for your listeners that'll give them a discount code once we go live. And like I said, we're only going to take the first 100, and they'll be able to get a discount off of that initial instructor price. So too easy. Thank you, man. We appreciate the privilege and the opportunity to have an opportunity to share. And I
appreciate you guys filtering those instructors, because I've been to classes where the person teaching tourniquets has never put a tourniquet on in their life, and who is they're like openly admit, I've never applied one in real life, but this is how you do it. And I'm like, okay, I just turned you off. Like, I just put you on mute. If you're going to teach me surgical crikes, I want you to know that you've done a surgical crike. I first want to admit, like, I have the skill. We carry crikes at our SWAT team stuff but I've never done a crike. So I'm not going to teach you how to do surgical crikes. Like I can't. Like, but I've done them on pigs. I've done them on high fidelity mannequins. But at 2:00 in the morning in a ditch or the back of a patrol car, I have not cut someone's throat. So I want someone to hold my hand and says, you know what, I've done it. I've done 5 or 6. I've done 18 of them, whatever. But so I agree that if you're going to sit up and tell me how to use a tourniquet, how to wound pack, how to put a chest seal, I hope that you've done it in the real world.
Well, and Skinny, I just want to say, and I think Bill attested to this too. It doesn't mean you can't help people learn those skills if you haven't done them. I've been practicing about 10 years, and I've done 3 surgical crikes, and every time it's all about preparation, mindset, and all the same things we've talked about. But I don't think that just because you haven't done one doesn't mean you can't help teach it. I just think that in general, we got to get rid of the ego and just realize our own limitations. And that's one of the great things about, that all of us have learned with working with the really high speed individuals we've had the chance to work with is the best people are very humble, and they learn from every interaction. And the people that are really insecure are the ones that tell you it's my way or the highway. And so if you get an instructor like that, be aware, but just because you haven't done something, I don't think it excludes you from being able to contribute. I just think you need to say, hey, I've never done this in real. This is how I would do it. But, crikes is a whole nother issue that I don't want to get into academically.
Yeah. And the key, you said, Josh, is don't pretend to be something you're not, because people are going to sniff that out. And I think we thought that way too in the beginning, Skinny. We're like, hey, if you haven't done this, you don't have credibility. And the things that makes me think of is, first off, we've got folks in the space that are creating curriculum, right? And writing slide decks that have never done it under the auspices in which we're teaching, and haven't done it in a ditch, like you said, at 2 a.m. Yeah. But I think we also figured out that if we're only going to hold it to where the folks that can teach this are folks that have done 15 crikes, or the folks that have applied tourniquets, we're really limiting the pool of people that will come in. Yeah. And so we get questions every day on the website. I'm passionate about this class. I want to teach people stop the bleed, but am I qualified if I've never done it? And that was another reason for the Academy. And what we're trying to use, we're trying to find a way to leverage our credibility in the space so that they can dovetail into that. Hey, I'm affiliated with this agency. We've got some video products. We've got some apps and things. So they don't have to necessarily stand up there and share a tourniquet application story, because we can do that through video for them. And then they can walk around and do the hands-on and check and do proficiency checks and do that part. And that's kind of what we struggled with when we first started teaching people. Like, we walked around, we were trying to turn people into us, and we realized you can't do that. Like, you have so much experience based on what you've done, Skinny, and spending 3 hours or spending 2 days with an instructor group doesn't give them that experience. They have to go out and get it. And frankly, I think the other thing, I think we base a lot of it off of the CPR program, right? You go to a CPR instructor class and then you start teaching CPR, and 90% of the people teaching CPR have never done it, to 99% of the public that never will need to do it, thankfully. And I think we're trying to replicate that, but it doesn't work, or it doesn't necessarily work in this space. So I think there's a fine line. I think you're right. I think it's a worthy discussion collectively we should have as to, what skill sets do you have to be certified up to what level of teaching? And I've worked with some guys that have never done a crike, but they can talk you through step by step, and they've done it on live tissue models. They've done it on, like you said, because that's something that frankly we don't do a lot of. The chest tube is the one that comes out to me. I've done a ton of live tissue labs for military, and we're teaching them all these things that are vital, and then they'll ask 500 questions about the chest tube. And I'm like, over the course of your 20 years in the military or whatever, you're probably going to do 3 of these, and they're probably all going to be in an emergency room with a physician standing over your shoulder talking you step by step through it. You're probably not going to pull this out in the ditch in the middle of the night. Doesn't mean you shouldn't learn it. It just, I think you have to look at the likelihood of you needing to recall this skill, and how much time is worth investing in this. How much gear do you want to carry for this? How likely is it you're going to need this?
I would definitely want to go Facebook Live if I was going to do a chest tube. We did some training with it last year, and I was like, this is the craziest thing I've like. This is so cool.
If any of your followers can do one, please Facebook Live that stuff, man.
Yes.
We want that video.
But yeah, like you're talking about like special forces guys, like they come through, like, and I agree 100%. They're so humble. Like I get a chance to meet quite a few of them, like through North American Rescue and other ways, and we'll go to lunch and I'm like, I want to hear their stories, but they're like, no, actually, well, what are you doing? I'm like, well, I took grandma to the hospital yesterday, and like they're so humble, and like they're like, those are the guys like I want to talk to. Like the guy who stands up and tells me, bows his chest, I'm like, okay, whatever. But the guy who's like really quiet, who's humble, like just listening, I'm like, that's the guy I want to talk to.
Yeah, I think Josh made a meme for me last year, and I was random. It came across like our group text, and it said, "See one, do one, teach one, kills many." It was great, and I'm like, but that's exactly how we were. Yeah. Because that model works in certain spaces, but that's not something the world should be adopting. Like, oh, you saw when you do one, now go and teach somebody else.
From the beginning, as soon as realistically, as soon as Homeland Security put us on their website and people would start emailing us, the first thing we would get is, hey, how do I become a first care provider instructor? And for years, Bill and I were like, what do we say to these people? Like, they don't even know what the course is, and they think they can be our instructors. So it's interesting. As I said, everything's an evolution, but I think we're in a good spot now where we've kind of identified that there is a community that's wanting some more, and they're wanting that interaction that they haven't been able to get previously. And a lot of them are, Skinny, they're your community. They're the people that are already looking at your reviews and your products, and they're actively trying to get better. And we want to unite that part of the world, hopefully give them some direction, but if nothing else, just let them share from our experience to hopefully help them be better, instructors at whatever they're doing.
That's awesome. Yeah. I mean, that's what this podcast was for too. We started doing YouTube on and off a long time ago, and that's kind of the market we were, wanting to reach. And then, nobody was really doing that on the civilian side when I first got started. And now, like in the podcast world, like that's a whole different environment. We've kind of figured that out. There's YouTubers, people who want to watch YouTube video, and then the people who are dead set on podcasts. So it's a whole different crowd. So it's definitely that's what we're trying to reach, is those people who just want to be more prepared, to have the mindset to want to help, and they just need a little guidance along the way.
Yeah, 100%.
Yeah, we've got some resources out there, kind of to put out. Like the one, and Josh kind of talked about a little, is we've got a Facebook group, called the Stop the Bleed Teachers Group, and you can request to get access. It's free. Anybody can get in there. We're in there every day, and when you first sign up, it's going to ask you 3 questions, and immediately, if you don't answer them, most of them are like yes, no, yes. They're literally yes, no questions, and immediately I decline people. If you're not willing to take the time to answer 3 yes, no questions, then that tells us you're not going to be a productive member of this community. And that's what we're looking for. There's so much negativity on social media, and there's so many people looking to snipe other people and have somebody pull their credentials and stick their chest out, like you said. And we have worked really hard to remove that. And if that's what you're there for, if you're there to sell stuff, if you're there to bang your chest and make yourself feel better, go somewhere else. Like, this is a community for people that get it, and people that want to make other people and want to serve other people. They want to make other people better and want to share what they've learned. And so we absolutely would invite folks to check that out. Like I said, it's Facebook, Stop the Bleed Teachers. Request to join, we'll let you in. And, and really it's about giving or asking. If you got a question, you need something, you're struggling with it, you need to share resources, whatever it is, the people in there are willing to help you. And, now it's such a robust community that by the time I get in there to answer a question, 3 other folks have already jumped in and answered it.
That's awesome. That's a good thing. Yeah. So what is y'all's, we'll kind of close trying to figure out the goals, y'all's goal for first care provider now and maybe into the future?
Well, I think, when it comes to, so there's a couple things, right? So, our first and foremost goal is we want people to stop dying at these terrible events, and when they happen, and we want to see an actual impact in decrease civilian mortality from trauma through Stop the Bleed and our program and all those other programs. And as a part of that, we want to see the success of the Stop the Bleed movement and the Stop the Bleed month continue to grow, and that's sort of a given. For us, for me personally, I'll tell you, we're really keen on sort of improving the education that's getting put out to the world, and again, just because there's a lot of assumption that I have XYZ degree, I have MD after my name, doesn't mean that I know anything about some of the things that you guys know about. And I'm always the first to say when I go out, when I'm going to knock on somebody's door in South Central to take care of whatever business we have to go take care of, I tell, my team and my medics that I'm just like, I have the same things that they have. I have some additional skills that maybe I can get to in the Bearcat, but we have to be able to sort of improve that education and be humble and get people to share. And like Bill said, and I heard online the other day, I'm tired of people whipping out their tactical, they unzip their tactical. And it's one of those things that, let's just, let's create something good. And then at the same time, let's develop some better learning models and actually, create some science here. There's basically in the literature right now, academically, all there are people saying, oh, we taught, XYZ Stop the Bleed course, and the people that took Stop the Bleed did better than people that didn't take Stop the Bleed. And that's great, but is that really advancing the science? Is that really improving the system? I'm not sure. I'd like to think that we could raise some awareness and advance the science a little more effectively than that. I don't know. Bill, what do you think? Bill, I think you're muted.
Yeah, sorry guys. Yeah, no, I agree. I also think, we're trying to leverage our relationships with the vendors and the heavy hitters in the space to be able to make the products more accessible and more attainable and more affordable for folks. We're trying to, again, as we mentioned earlier, standardize what the message is and simplify it. And we're trying to make sure that the folks that show up wanting, like you said, Skinny, on a Saturday morning, that are willing to give up their time, that those folks are served, that they leave every class that they go to, whether it's a first care provider class or whether it's a Stop the Bleed class, that they leave better prepared than when they got there, that their time wasn't wasted, and that they're far more likely to do the right thing on the worst potential day of their life. And that's really what the crux of what we're about. And the other thing we haven't been good at, to be completely honest, is we do this. This is not a paid position for us. This has been a labor of love. And the cost of this is, we both have full-time jobs, multiple full-time jobs. And we do this because we feel called and we feel the compassion and the need to do it because nobody else is doing it. We would like to move this into, the full-time realm, but we haven't done a good enough job of we were finally getting more people on board. And so if this is something you feel called or compelled to join us in the movement, we realize we can't move this mountain alone. And we're far better prepared, and we're doing much more collectively than we'll ever be able to do, with the small unit group of us. So our goals moving forward are to expand the network of folks, share and pool resources, and just continue to educate the world and do it the best way possible and to serve people.
Awesome. I mean, I really am excited for you guys. I'm excited to see what happens in the next year, next 2 years, with the program, and hopefully becomes like the HA of CPR. Like that's where I would like to see it, honestly, is. Well, so that's
hopefully you get Skinny Medic, you can go to your website and start signing up for first care classes.
Absolutely. That's what my goal is. We're going to start probably in January, roll out the first care provider course. I think that's our goal right now. We're going to finish up the year traveling and got a couple of events coming up, but I think that's what we're going to roll out in January for us, is to start teaching first care provider courses.
Awesome.
That's awesome. I know you asked Skinny about our podcast. We do have a podcast called the Citizen Heroes Podcast. We just launched the second season, and we got some there's some great episodes there to go back. And the concept of the podcast was to share stories of everyday citizens that have done extraordinary things under extremely difficult circumstances. And the problem with doing a podcast of that is getting access to those people, right? That's a small subset of people. We know that people are out there every day doing great things on the side of the road or wherever it is, but connecting with those people is difficult. So, if people want to check out the podcast, please do so. Like I said, it's Citizen Heroes. But what we really need or, have them connect with us. If you know somebody or you're somebody who's done something, you've raced to safety, or you've done something to save somebody's life, or done something in an emergency that's made a difference in someone else's life, we would love to share that story. And we get a lot of first responders who are doing amazing things, and that's great, and that's worthy of sharing. But I think that a little bit flies in the face of the message, because what the public says is, well, of course he did that. He's a first responder. And our message is that you can do that. Ordinary people can do extraordinary things under duress. And we want to celebrate and share those stories. So that's what we're looking for. So if you have folks that you want to put in touch with us, you can reach us at info@firstcareprovider.org. And we would love to have them. And the other thing that I think we were surprised with, the first episode of the second season, two young ladies that were involved in the Route 91 Harvest Festival shooting in Las Vegas, and their story is incredible. But what we found, and we interviewed a couple people from that, we also interviewed a firefighter from Vegas, is they find some healing and some moving, some growth and some development in sharing their story. And they want to share their story because it's helping them move on beyond it. And they also feel something good is coming out of it. If I can teach other people to learn some lessons from what I was exposed to and didn't have a choice to be exposed to, then that helps me heal and it helps me move forward, and I want to share. So we want to provide those folks an opportunity to do that, to heal and to move on and to share their stories, and give people an opportunity that, heaven forbid, the worst day of their life comes knocking, that maybe they've thought about some things they might not have thought about elsewhere.
That is awesome. Yeah, I mean, I listened to one of the survivors from Virginia Tech, and just to hear her story, like, she's passionate about it. She's passionate about her story, about her survival. She wants to help other people. And so that, like, I love hearing those stories. I love getting emails saying, hey, I've watched your video and I was able to help someone in a car wreck or something like that. So that definitely motivates you to keep going, because this is hard. This is hard stuff you guys are doing, I'm doing. So yeah, it gives you that motivation.
I tell people all the time, I was just saying that to us, that's the paycheck, right? That's the greatest gift you can receive, is having somebody you train come back and tell you that they employed the techniques that you showed them, or they did something that you taught them to save a life. Like, there's no greater reward than that, no greater feeling.
Absolutely. I mean, because we're not getting rich doing this stuff. Nobody's a rich paramedic. Nobody's a rich EMT. I mean, there are rich doctors out there, but you know how that goes.
We could have gone the whole time without doing this. Come on. Okay, fine.
I was proud of myself that I didn't make an Air Force.
Yeah. So that's the thing, when you're an Air Force, veteran and a doctor, all you're going to get is Air Force jokes and doctor jokes. And I'm good with that. That's all right. Just remember,
too easy.
Listen,
too easy.
The next, I've got a cell phone full of, hey, did my kids need stitches? Just remember, my price goes up every time you make a joke.
That's funny. Yeah, I love, one of my side jobs is teaching at the medical school. So in the first year residents, or first year medical school students come in, they get their EMT. So I love teaching them. And then I love them 4 years when they go into residency and they're continuing doing that stuff. And they're like, I want to go back to EMT class. EMT class was so much fun.
Sure.
So I love them.
All right. Well, thanks for looping me in with all the rest of them. It's funny because when there's a whole sort of career field where the description is, well, some of them are good, like when you're talking about tactical docs or operational docs or whatever, and the barrier to entry as well, some of them are good. It's pretty low bar.
No, I love having a doctor on my calls. Sometimes our med control will come out and do stuff, and I'm like, this is awesome. this is good stuff. I love, for a team, you were saying, you're doing some stuff in the neighborhood stuff, and to have a doc on there that, that's freaking cool. That's awesome.
Well, yeah, but I'm just a doc doing medic skills that a smarter medic than me taught me at some point in my life.
Awesome. Well, I appreciate you guys coming on. We'll put links down below to all the descriptions. And we gave a lot of information in this podcast. So anything else you guys want to cover? No, just thanks for the opportunity. And, the folks that
are checking out your program and following along, they're our type of folks, right? They're people that want to make a difference in the world, and they're people that want to spread the message. So we want to be encouraging, and we want to thank you for what you're doing, especially if you're one of those folks who've really taken the challenge on and you stepped up to teach people. You should be commended for that. And you're spending your money and your time to make the world a safer place. So kudos to you. And thank you, Skinny, for, I know it's not easy. We produce content too. And there's days when you don't feel like recording a YouTube video. And there's days when you feel like nobody's going to watch this or listen to this. So, you've been at it a long time, and you've amassed a big following, and that's not by accident. So kudos to you for sort of, we stay in the course, which is what Josh and I constantly have to remind ourselves to do. Stay the course.
I think I may have been the first one to mention you guys on YouTube, like years ago. I think it was when I don't know if it was when I talked to Bill or John. I don't remember who I talked to on the phone, but it was years ago. I said first care provider is going to be the new term, and that was years ago. And I was reading, and I don't remember where the article was at. And I was reading about first care provider. I was like, this is cool. This is the next big thing. So that was
Sweet.
That's been a while back.
Listen, we're there definitely been some early adopters.
Now let's make it big.
I really, I completely remember that. And, I actually run that in a loop as my phone, when my phone calls come in, it's you talking about me. So anyways, but no, it means a lot. But more than anything, it's just, we're looking for, there's a lot of people in the world doing this stuff. We're looking for the guys and gals that get it and that are doing it for the right reasons. And, it is a labor of love. But you know what, if not us, then who, right? So we're going to keep doing what we're doing. You keep doing what you're doing, and, beat Army, beat Navy. They play for second.
Awesome. Well, I appreciate it. So we'll put links down for everybody down. And then I appreciate you guys taking some time out of your day to come and talk to me.
Sounds good. Bill, you want to send him a link to the IDA?
Yeah, I'll send him. Skinny, I'll shoot you a text with all the links I mentioned. Too easy.
Yes, sir. Sounds perfect.
You can get in. So Dietrich, so you can actually get in.
Thanks, man. We appreciate the opportunity. Thanks.
Yeah, definitely. Like I said, my goal is to do.
Yeah. I'll send it to you right now. In fact, you can view the course right away, and I'll put